Okay, so I will talk about safety, about terminology, and about reporting. This sounds somewhat boring. So we have that safety issue, and we already saw how many injections have been done, and the safety issue is as a take-home message that you might face in 1 out of 10,000 injections severe reactions. And those are complement activating reactions. That means they depend on complement activating processes independent of IgE, and it's not after exposure. So it's the first injection in your life you are facing such CARPA reactions. And they are, how to say, treated like an anaphylactic reaction, but they are finally pseudo-allergic reaction, and the best thing is to watch and wait, or you might inject the same drugs as for anaphylactic reaction, but watch and waiting is a good strategy. The side effects in children are reported to be higher. So if you go into children reports, we might face some important reactions in 1 out of 100. So it's 100 times, let's say, more frequent. But the answer might be that we take more care of any kind of reactions, that placebo reactions might be also more frequent, but this is somewhat, how to say, a story we have to solve, and the most important thing is that we have the feasibility for resuscitation in all circumstances, and finally that's all. In more than 20,000 examinations I'm aware of, I faced this CARPA reaction 1 time. And it's some sort of stenotic pain over the chest. It is a hypotension, it's a lumbar reaction, and it's somewhat strange for the patient and for us. And it showed also in that case ECG changes which are similar to myocardial infarction, but finally it was not myocardial infarction, and we didn't do anything for that patient except to have that patient on the intensive care unit. From Professor Fabio Piscaglie, we had that beautiful study in Italy which showed that serious events are expected in 1 out of 10,000. The reaction, CARPA reaction, as I mentioned, is a reaction which is dependent on the liposomes which are part of the contrast agent. Theoretically, they might be a reaction of the content or the liposomes around of the gas. So right now I would love to show let's say also a few images. What Peter Burns has already mentioned is the strict intravascular application of the contrast agents. And I would love to ask you if a fetus, after injecting the contrast agent to the mother, to some of you, the fetus is enhancing contrast agent. Some of you, yes or no? Who is in favor that the fetus also is enhancing? Raise your hand. Who is not in favor that the fetus is enhancing? Almost all the others. So that was a young lady who had growing liver lesions, and you can quite nicely see the placenta in that case. And there is no bubble at all in that fetus, and the placenta is nicely working. So the contrast agent is strict intravascular. We have seen that superficially located aneurysm from Hans-Peter Westcott, but here you have pseudoaneurysm, and we had the wrong diagnosis by CT that there was a hemorrhage in a pancreatic pseudoaneurysm. But it's not, let's say, the hemorrhage, it's an active bleeding. And you can see real time the pseudoaneurysm of the pancreas, and you can see the yes-no response. There's no bubble at all in the surrounding. We have that real-time imaging. We can see it's active bleeding, and we have the yes-no response, the strict intravascular supply. Okay, my final conclusion is resuscitation facilities should be available. You won't need them in almost all circumstances, but you should be aware of that. SonoView is safe. I saw that same sentence in the lecture of Peter Burns and Neil Nozere. Do not use CEUs if not indicated. So before you do an injection, raise the question you like to answer after that injection with a yes-no response. Don't do disciplinary approach. Have one question, one answer. Try to make it KISS. Keep it short and simple. So if we have such a lesion like this cyst, there is no doubt about it that this cyst has all that important criteria of a cyst. We do not need any kind of injection. First of all, the contrast agents have been developed to enhance Doppler signals. I heard that before. And here you can see nicely the right adrenal gland next to the inferior vena cava and the liver. You can differentiate the right adrenal gland from the diaphragma. This should be done always. And there's no CT and no MI. You might never have seen the supraadrenal gland vessels by itself. So you can see the arterial vessels, you can see the venous vessels, and you can even see it transcutaneously. The better the machine, the better the delineation to enhance Doppler signals. Honestly, this was without contrast agent, but still the original purpose was to enhance Doppler signals. Now we are talking more about terminology and mainly about the liver, but also about other organs. And we have phases: arterial phase, portal venous phase, late phase. And this depends for sure of the organ examined, but the most organ examined so far is the liver. And I wonder in which temporal sequence the enhancement happens. So we have the injection, we have that enhancement of the heart, lung, aorta, liver. What is first, what is second, what is third? Okay, first have a look to that heart. And here we can see some contrast in that heart. Which contrast agent? SonoView, Echovist, or spontaneous echoes? Who is in favor of SonoView? Raise your hand. Who is in favor of Echovist? Raise your hand. Who is in favor of spontaneous? Raise your hand. Most. Those are spontaneous echoes by new machines, and we have to be aware that those spontaneous echoes may develop. For echovist, it would have been in the right heart and not in the left heart, so we have to be there was a little tricky situation inside, but let's have a look. Okay, the heart. Right now we inject the contrast. It's a patient with an amyloidosis, and we see the enhancement in the right heart, in the left heart, and in the myocardium. Right heart, left heart, myocardium. Okay? Now we have a lung, we have a liver, and we have the heart. So injecting would mean it first comes into the heart, second heart, lung, and let's wait when it comes to the liver below the diaphragma. Right now we have the enhancement pattern in the liver as well. Let's say 7 to 10 seconds later. Lung, aorta, liver. So this is a range of real-time enhancement pattern you can see and you can differentiate by contrast-enhanced ultrasound. Right heart, left heart, aorta, lung, aorta, and the liver. So this can be displayed in real time. And if you look for the phases, look for the arterial phase with respect to the hepatic artery. Here you can see hepatic artery, you can see the central vascular supply. And if you look for the portal venous phase, look for the portal vein, and you see the portal venous enhancement in comparison to the surrounding liver parenchyma. No, better in comparison to the portal vein. You can nicely display this in the liver. If we talk about terminology of arterial phase, we have that early phase, that late arterial phase. It might enhance entirely, in whole, or in part. It might be a homogeneous enhancement. It might be a peripheral enhancement. It might be one central vascular supply. It might be an eccentric vascular supply. It might be multiloculated. It might be peripheral nodular contrast enhancement and centripetal fill in, or it might be rim enhancement and others. And I will give examples. So this is homogeneous early enhancement of the entire lesion. Next to the heart, this lesion was not even seen by CT. Here you can see it is hyper-enhancing in the later phase. It cannot be malignant. After 2 minutes, if it's hyper-enhancing, there are almost no reported lesions which are non-benign. It was an FNH, one type of FNH. It might be enhancing partially. You have that typical mosaic enhancement in hepatocellular carcinoma. It might be a centrally located first enhancing artery. But Peter, Doris, and others might say, I don't believe that centrally. Why isn't it from the periphery? And you might have that, let's say, image only in the center. So there's a lying detector. You can use parametric imaging. Yellow is early, green is a little later, and blue is thereafter. So ultrasound allows the fourth dimension not only to provoke, it might be centrally located. You can see it's a centrally located vascular blood supply. And this cannot be malignant, first of all, because it has such a well-built vessel architecture. You can prove that this is focal nodular hyperplasia. Focal nodular hyperplasia might have 4 types: homogeneous enhancement, central arterial blood supply, nicely seen here. Third is not centrally one vessel, it's eccentric one vessel. And the fourth is, if we look to that teleangiectatic FNH, after biopsy it was hepatocellular adenoma, it was FNH, hepatocellular adenoma, it was FNH. Right now they are classified according to their molecular imaging methods histologically to hepatocellular adenoma, but they show features, vascular features of focal nodular hyperplasia, and they have portal vein branches, and hepatocellular adenoma do not contain portal vein branches. Okay, here we have that peripheral nodular contrast enhancement. You can see nicely the peripheral located nodules. And as mentioned by Professor Peter Burns, you can show 4, 8, 64, 128 3D images in one image to determine the time intensity curve analysis and the perfusion pattern, not only by 3D, but also by 4D. The rim enhancement is a ring or rim enhancement, not peripheral nodular contrast enhancement by hemangioma, but this is something which is typical for metastasis or cholangiocellular carcinoma. And you have that washout a few seconds thereafter. The washout for terminology might be mild and or early, or might be late and punched out. So we have to determine for differential diagnosis of hepatocellular carcinoma in the liver imaging reporting and data system that HCA have typical late and mild washout in a liver cirrhosis. Typically early and punched out washout is more typical for cholangiocellular carcinoma in a liver cirrhosis. So that terminology might be used in the daily practice. One more question. The beginning of the portal venous phase starts 40 seconds after injection, as we know from CT, 50 seconds after injection, or 4 to 6 seconds after the beginning of the arterial phase. Who is in favor of 40 seconds after injection like CT? Raise your hand. Who is in favor 50 seconds after injection? Who is in favor 4 to 6 seconds after arterial enhancement? I love it. So this is one of those images of the European approval study of SonoView, so very early 2001 or something like that. You can see the central arterial blood supply, and look to the right to the portal vein in a few seconds when the image starts again. So we have in a few seconds the arterial enhancement here, and portal vein right now with 3, 4, 5 seconds starts to enhance. So for radiologists it's difficult to understand because they do a totally different examination technique, that portal venous enhancement in a strict intravascular agent behaves differently. And we have not the mix of whatever enhancement patterns in a portal venous phase in CT, but we have a different kind of imaging of that phases. Here you can see arterial, the enhancing lesion, and the portal vein, hepatic artery, arterial enhancement of that metastasis, and portal vein not enhancing. And you have a few seconds later hypoenhancement, or we call it washout of the lesion, and this happens during the process when the portal vein is enhancing. And a little bit later we have that marked punch out, wash out, a typical finding of metastasis. And you might think it's a fake, but let's see how it looks. Red is hyperenhancing, orange, and blue is hypoenhancing. And this lesion is hyperenhancing, and a few seconds thereafter, it is blue, hypoenhancing. Right now, look, hyperenhancing, portal vein is non-enhancing. The portal vein starts to get bubbles, and the lesion is hypoenhancing. So this change from hyperenhancement to hypoenhancement or wash out might be a process of a few seconds. And this you can see in a parametric, in a lying detector way. Orange is hyperenhancing, blue is hypoenhancing. So there is no doubt about it that it shows that feature. Non-enhancing, why it is of importance to guide biopsies. We have seen so nice images, therefore I cut it out from my presentation. But that was an old lady and she had a little mild abdominal pain. It was a subilius image. I was looking to the inguinal region and you can see something looking like ovary or whatever. This is the inguinal channel, or it's a femoral channel. No, it was a femoral channel because this was at the inner part of the femoris. And I was interested, or it was so important about planning the operation to see if that bowel structure was enhancing or necrotic. And you can see that the bowel wall was enhancing quite nicely, so we had time for operation, and 3 hours later the patient was operated, and we had that diagnosis. It was mild abdominal pain, and let's say the patient was overnight without any care before that ultrasound examination, and the question was if that tissue, that bowel wall, was ischemic, necrotic, yes or no. You can see that lesion here, focal lesion, it is a metastasis of GIST, gastrointestinal stroma tumor. And right now we are in March 2007. And in May 2007, there is a non-enhancing lesion. CT showed RECIST criteria, no change. But this metastasis has responded to imatinib treatment. And this was not seen by size, but by the enhancement pattern. And more than 10 years from this, right now the patient had no recurrence of metastatic disease in that region. Dynamic contrast enhanced ultrasound allows to give time intensity curve analysis, might be as bolus injection or replenishment. We have seen nice replenishment examples, and ideally that time intensity curve analysis should be independent of ultrasound equipment, data acquisition, and analyzing the software. And we have different parameters from the enhancement pattern up here and downward. We might summarize in 7 parameters, time and amplitude dependent parameters. Peak intensity, time to peak intensity, mean transit time, and area under the curve criteria. One more question. Which parameters are more stable, time dependent parameters or amplitude dependent parameters? Who is in favor of amplitude dependent parameters to be more stable? Raise your hand. No. Who is in favor of time dependent parameters are more stable? A few ones. Yeah, if you increase the gain, you might change really the amplitude dependent parameters. So the time dependent parameters are the more stable ones. If you are interested, free on the EFSUM website, European Federation of Societies for Ultrasound Medicine and Biology, you can read about all that parameters terminology of that dynamic contrast enhanced ultrasound. Reporting CEUs, use anatomic terms whenever possible I will give an example. Here we have that large folds of a gastric cancer, lymphoma, or a large fold, whatever disease of the stomach. And this is the B-mode image of the large fold. Even here you can see the muscle proper layer quite nicely with the inner ring and the outer longitudinal part and the septum in between. And you can see that this is not part of the muscle proper layer, but of the mucosa and submucosal layers. And the contrast enhancement is from periphery to the lumen. And you can see the muscle proper layer, which can be even better seen by endoscopic ultrasound. So here we have the muscle proper layer and the contrast enhancement by endoscopic ultrasound, and we can see all that lines quite nicely. And ultrasound helps us in daily routine that this is not an infiltrating, let's say, gastric carcinoma beyond the border, but you can see it's a large gastric fold gastritis, which is called Menetrier's disease in that circumstance. Reporting. It's a never-ending details you might add to that, but always document the examiner, document the machine settings, the contrast agent, the dosage by text and by images, and if possible by videos. Document the indication and make a risk-benefit alternative balance. What is the question of the contrast enhanced ultrasound study? If possible, go for one question to be answered. Look for and document if the sufficient quality of images is achieved in general and for the specific purpose. And distinguish the description of the findings in major or decisive ones and in ancillary features. So for the liver, a major feature is in a normal liver, hyper-enhancing in the portal venous and late phase after exclusion of liver cirrhosis. It's a benign lesion. That's a major information. And then you look if the enhancement is from periphery to central, if we have a central arterial blood supply, homogeneous blood supply, multilocular blood supply, or whatever. Those are ancillary features and they give additional information. So the washout in the normal healthy liver is most important. And then give finally the ultrasound diagnosis and give further recommendations if we need biopsy, additional staging images or whatever. And this is about the documentation. So we've been talking about safety, terminology and reporting. And I hope there will be a little bit bright light after this presentation. And merci, thank you so much.